Taiwan population around 23 million, and our birth rate about 200,000 per year. So the Taiwan is look like a sweet potato, and my city is located the southern of Taiwan. So this is maybe 80 years ago's patients. She's a grandmother took him in my clinic because she had a larger tongue. Because this is a lack of newborn screening. So the lab data showed very high the TSH level and very low T3 and T4. Immediately the thyroid scan was performed, showed the typical ectopic thyroid here. Then we give her 2 months as at level thyroxine. The pictures is much improved. 8 years later, she's grown up, and the mentality almost normal. So the development of newborn screening of metabolic disorder in Taiwan had started 1984. There are covered G6PD deficiency and congenital hypothyroidism and galactosemia and PKU and homocystinuria. And till to the 2000, the CAH screening was performed. Then MS study also doing. And till to the 2010, we have screening more lysosomal storage disease, include the Pompe disease and Fabry disease, even MPS. We can newborn screening. By the way, the SCID also screening in this program. So how to procedure of the newborn screening? The baby after birth. Okay. The baby's after birth with feeding, the blood spot about 0.0 cc was performed, and the blood spot will be mailed to the newborn screening center. If the TSH level over 20 milli-IU per liter, immediately this report sent to the confirmation hospital, and we have to following the evaluation, include the thyroid function, thyroid antibody, and the thyroid scan. So the control mechanism of hypothalamus and pituitary thyroid function is the TSH was secreted from the anterior pituitary gland, then regulated the thyroid function. The thyroid will be secreted T3, T4, and feedback to the pituitary, anterior pituitary gland, and feedback to the hypothalamus. So if the primary central hypothyroidism means TRH cannot feedback and no more, that the thyroid function TSH is not so high. But the primary hypothyroidism, we detect TSH. So sometimes the stress may inhibit the effect of TRH secretion, and some medication, dopamine and somatostatin, will acted as a pituitary label to inhibit TSH secretion. But most of the congenital hypothyroidism is we screen the TSH. This is confirmed what's the problem of the thyroid gland. Usually we use the technetium 99 scan to detect the thyroid gland. This is a genesis of thyroid. This is ectopic, a small uptake thyroid gland here, and a normal thyroid gland, and this is a goiter of thyroid. And sometimes the thyroid uptake is not so good, it's a hypofunction. So this study just introduced congenital hypothyroidism affect 1 in 3,000 to 4,000 newborns, and 1 in 2,000 in Taiwan, more than twice as much female as male. And children with thyroid agenesis or ectopia, about 85% usually need permanent levothyroxine treatment. The thyroid dishomogenesis due to error of thyroid hormone synthesis, about 10% in total congenital hypothyroidism. Anyway, we should be consider transplant center maternal thyrotropin receptor binding antibody, about 5% cause of congenital hypothyroidism. Most of the congenital hypothyroidism is sporadic, and some of patients familial or the goiters or non-goiters on the thyroid scan will be found. This figure is show us thyroid hormone synthesis. When the thyroid regulation, the thyroid regulation by the TRH, so the anterior pituitary gland secreted TSH, they have a receptor, we call the TSH receptor. Can as well as the function steps of thyroid hormone production. The key element of thyroid hormone production is transport of the iodine into the membrane, into the cell, and the iodination of the tyrosine ring of the matrix, the protein thyroglobulin in the follicular lumen by the TPO and the H2O2, generated by the Dulix enzyme system. So if we wanted to know the TSH receptor is the major cause of congenital hypothyroidism, so we procedure this the background of the study for congenital hypothyroidism via TSH receptor mutation in Taiwan. So most cases of congenital hypothyroidism are sporadic. In CHT cases that are inherited, most are an autosomal recessive manner, include CHT due to the TSH receptor mutation. And the TSH receptor gene is located on chromosome 14q31 and encoded a transmembrane G protein complex the receptor. Among these mutations, the most common is 349G to A. It's R450H, the mutation is most common, in particularly as a TSH receptor loss of function mutation. We reviewed one paper, the reported by the Manumi Japanese in 2009. in the journal Clinical Endocrinology, the Metabolism. That show the TSHR mutation as the cause of congenital hypothyroidism in Japan. And population-based genetic epidemiology studies is showed 4 common mutation of TSH receptor, except the common this one and 1207G2A and 394G2A and 611C2T mutation. But this is jeopardized TS-induced AMP production as well as TSH receptor the binding activity. So according to this study, that we wanted to know how about the congenital hypothyroidism in Taiwan. So we collected 149 patients. The gender is male, only 38%. The age is around 5.6, and thyroid morphology was done about the 52 is goiter and genesis or ectopia, and 47% is functional or normal thyroid morphology. And the normal controls is 334 cases. So the genotyping was performed by the RFLP to detect the TSH receptor mutation. The TSHR450H mutation was genotyping by PCR as this gene. So the result showed that the TSHR receptor mutations was determined by RFLP. So this is a GG type and the GA type and the AA type. And this is a normal controls. Yeah. The result of our study showed the genotyping and alleles the frequency of TSH receptor mutation R450H mutations and controlled group. We showed the AA genotyping in one case, about the 1%, and the GA genotyping was four cases, about 5.6%, and the GG normal genotyping over 66 cases. So the 93% is a GG normal genotyping. And the normal controls group, we find 1 cases, about 0% is AA mutation. So the AA and the GA mutation overall in 5 cases of congenital hypothyroidism. So the instance is about the 7.0%. The standard deviation, the p-value is 0. The p less 0.01. So it is a very significant difference between the TSH receptor mutations, congenital hypothyroidism pace, and in control group. The clinical finding of the congenital hypothyroidism patient with TSH receptor mutation, we talk about the R450H mutation in our study, but we didn't find the other 3 kinds of mutation in our study. That is a difference finding from the Japanese result. we analysis the 5 cases of the TSH receptor mutation. The number 1 case is homozygote AA the mutation, and the other 4 cases is heterozygote the mutation. The gender is 4 cases male. Only 1 case is female, and this case is younger brother also have microsoma antibodies positive, and the blood bladder level of TSH was detected at the newborn screening. All is no abnormal. And serum TSH level also very higher than normal. And the TSH level at the diagnosis, some cases below the normal range. And the thyroid scan all have functioned, except 1 case is hypofunction. And the next study was performed by the case of a congenital hypothyroidism case. This is the background of the role of the thyrotropin releasing hormone. It means a TRH test in re-evaluation of congenital hypothyroidism the patient. We reviewed the 2013 one paper from the Davis. This is a study about the role of the thyrotropin releasing hormone stimulation test in the diagnosis of congenital central hypothyroidism. The central congenital hypothyroidism usually was found Caucasian people in infancy. The majority of the patients have multiple pituitary hormone deficiency. We call the MPHD. So can we use the TRH test to evaluation of congenital hypothyroidism? It means the primary congenital hypothyroidism is not a central type. So the role of the thyrotropin releasing hormone test is re-evaluation of congenital thyroidism at 3 years old for those patients with euthyroid gland to decide where thyroidism persisted. So this paper was published in 2014 by myself. Yeah. So what the etiology may cause the except the congenital hypothyroidism, we have considered a transient congenital hypothyroidism. What's the meaning of transient hypothyroidism? It is about 5 to 10% of infants detected in newborn screening. That times they are low or normal T4 and vary above the elevated TSH. And goitrogenic agent or transplant centrally derived TSH receptor blocking maternal autoantibody, and sometimes caused by the thyroid scan show the values, or sometimes have iodine inhibits or goitrogens increased uptake of technetium. And the presence of in maternal or neonatal blood of high level of TSH receptor blocking antibody is mean the TBA. Sometimes the transient congenital hypothyroidism will persist beyond 1 to 2 weeks. Treatment is in order. So the second factor cause the transient hypothyroidism is called euthyroid hyperthyroidropinemia. It means only TSH elevated. It's about the 1 in 18,000 newborns. And elevated TSH sometimes higher than 17 to 77 ml per liter at 2 to 7 weeks of age. They have a normal T4, T3, and free T4, none on TBA antibody, and normal thyroid scan. There will be increased TSH response to the exogenous TRH in infants, and persistent for 3 to 7 years in children. Mechanism remains obscure. Mutation in sometimes reported mutation in TSH receptor gene. Usually treated in newborn in free T4 in the upper half of the normal range. So this study was performed in our hospital. We collected 228 patients in utopic condition, and 19 cases of agenesis of thyroid gland, and 30 cases ectopia, congenital hypothyroidism. The label of the initial label of screening and confirmation, the TSH very, very higher in agenesis, the best higher in agenesis of hypothyroidism. And the second one is ectopia, is the second one. And utopic condition, the TSH is higher, but not so higher than the other two kinds. And the T3 label is very, very low in agenesis group. And the T4 also the best, the most lower label in agenesis. And T4 and T3 label also maybe range from the lower normal range. And the free T4 also very, very low. So these three groups we have studied difference is show that agenesis is more severe cases in the congenital hypothyroidism. So the thyrotropin releasing hormone test was performed. The patients with utopic thyroid gland and reached 3 years old after stopping levothyroxine treatment for at least 4 weeks. Then thyroid hormone, free T4, T3, and T4 and TSH level was measured immediately prior to when intravenous TRH, the dosage is 7 microgram per kilo, was administered. The TSH level was assessed against 30 minutes and 60 minutes and 90 minutes later. So the figure shows the distribution of the transient hypothyroidism, thyroidropinemia, and permanent congenital hypothyroidism with baser TSH and peak TSH level. The triangles mean the permanent congenital hypothyroidism, and the circle is transient hypothyroidism. So the figures showed the most of the permanent hypothyroidism, congenital hypothyroidism, the TRH test, the peak TRH level is very, very higher. very high. But in other words, they have some circle. Circle is transient hypothyroidism. Transient. Maybe some cases has a upper label. The peak level of TSH maybe over 16 microliter per liter. So some data are overlapping here. So the instance of the transient hypothyroidism and the permanent congenital hypothyroidism according to the sex and the basal TSH and the peak TSH label. This figure showed the 137 cases about near the 70% is male, and females is 91 cases, and the permanent congenital hypothyroidism, the male and female almost very similar, and thyroid scans hypofunction about the 68% in the hypofunction, and normal is normal thyroid scan and hyperthyroidism is around the 60% to the 70% is in the thyroid transient hypothyroidism, but in the permanent hypothyroidism, they have normal functions, normal thyroid uptake near the 29%, and hyperfunction is near the 40%, and hypofunction is the same, the 31%. The basal TSH label is mean the first time of blood tapping is a basal TSH label. The below the 4.6 MIU in the transient hypothyroidism is 100%, but the permanent congenital hypothyroidism is 0, and over the 4.5 milli IU per liters is is higher than the 43.6 in permanent congenital hypothyroidism. The peak TSH is mean we draw blood to check the TSH first time and the second time and the third and the fourth times. We can comparable the transient hypothyroidism is 100%. Below for the peak TSH below 40 milli IU's case is in about the 93 cases, and over 60 milli IU per liters is around near 20%. But the permanent congenital hypothyroidism is over 80%, is higher than the 60 MIU per liter. So this is a difference. We find the standard deviation is a significant difference in the base TSH and peak 60 MIU per liter. So the conclusion is find the R450 TSH receptor mutation in congenital hypothyroidism in Taiwan children. Approximately the 7% of congenital hypothyroidism had a heterozygote or homozygote TSH receptor mutation in 134 C9G28 mutation. It's very, very common. But it is a difference from the Japanese population, which may relative important in the Taiwanese children with congenital hypothyroidism. The conclusion, the second conclusion is the role of thyrotropin releasing hormone test maybe it's a method to re-evaluation of congenital hypothyroidism. This kind of procedure may prevent some patients to have to take levothyroxine a long life. So the clinical evaluation of a TRH test was performed at the age of 3 years for ectopic congenital hypothyroidism and neonatal hyperthyrotropinemia to avoid over or under treatment. So I will thanks to my colleague, Dr. Mei Chyn Chao and Mei Chyn Chao. They are Department of Medical Genetics and College of Medicine, Kaohsiung Medical University. And my colleague from the Division of Genetic, Endocrine and Metabolism, Department of Pediatrics and Kaohsiung Medical University Hospital in Dr. Chen Limin and Dr. Xiang Huibing. Yeah. So this is my work here at Kaohsiung Medical University Hospital. And this is my lovely lived Kaohsiung City. They have a lovely river. So welcome our audience can visit our country in the future. Thanks.